Cerebellar disorders manifest through distinct deficits in motor control, beginning with ataxia, which is characterized by a reeling, wide-based gait. Movement decomposition occurs when a patient is unable to sequence fine, coordinate acts correctly during tasks like the finger-to-nose test. Dysarthria involves an inability to articulate words correctly, often presenting as slurring or inappropriate phrasing. Scanning or staccato speech is a specific abnormality where there is a slow, explosive enunciation with hesitations at the beginning of syllables. To elicit scanning speech, ask the patient to pronounce multisyllabic words like Mississippi or Venkataramana. Notice distinct pauses before each syllable as the patient struggles with prosody and articulation. Dystiatochokinesia is the inability to perform rapid, alternating movements, which is typically tested through thigh patting or finger tapping. Dysmetria describes the inability to control or limit the range of movement, often resulting in overshooting. Nystagmus presents as a rapid oscillation of the eyeballs in horizontal, vertical, or rotatory directions. The fast component of the nystagmus is usually maximal toward the side of the cerebellar lesion. Hypotonia is a decrease in muscle tone that is often ipsilateral to the side of the cerebellar lesion. It is more noticeable in the upper limbs and proximal musculature during acute hemispheric insults. The pendular knee jerk is a classic sign of hypotonia where the leg keeps swinging after the reflex test. A result of more than 4 times is considered abnormal, while 4 or less is normal. Cerebellar tremors are rhythmic and oscillatory, affecting limbs as they approach a target, known as an intention tremor. Postural tremors affect proximal musculature when the patient attempts to bear weight. The finger-to-nose test requires the patient to partially extend the elbow and rapidly bring the index finger in a wide arc to the nose. In cerebellar disease, this action may manifest as an intention tremor or past pointing overshoot. For the heel-to-shin test, the patient should be in a supine position to eliminate gravity's effect. The patient slides one heel down the opposite tibia, observing for jerky or wavering movements. The Stewart-Holmes rebound sign occurs when the patient pulls on the examiner's hand and the examiner suddenly releases it. In cerebellar disease, the antagonist muscles fail to contract, causing the limb to continue moving uncontrollably. Foot tapping tests can pick up even minimal cerebellar disease by comparing the rate and rhythm of forefoot patting. The patient sits with feet flat and is asked to pat the floor repeatedly. Balance requires 2 out of 3 inputs: visual confirmation, non-visual proprioceptive or vestibular input, and a functioning cerebellum. The Romberg test is positive if a patient loses balance immediately upon closing their eyes. Sensory ataxia is characterized by a positive Romberg sign and is often due to lesions in the posterior column or severe neuropathy. Patients may report the wash basin sign, losing balance when splashing water on their face. Vestibular ataxia results from lesions in the vestibular pathways, presenting with vertigo, tinnitus, and hearing loss. The direction of nystagmus in these cases is typically away from the lesion. Frontal lobe ataxia, or Brunn's ataxia, features a magnetic gait where the feet appear stuck to the floor. This is often caused by conditions like normal pressure hydrocephalus, also known as NPH. The cerebellum is divided into functional zones: the midline zone, the intermediate zone, and the lateral zone. The midline zone, including the vermis, controls posture, locomotion, and extraocular movements. The lateral zone and dentate nucleus are responsible for planning fine and skilled movements in connection with the cerebral cortex. Loss of function here leads to hypotonia, dysmetria, and kinetic tremors. A normal gait cycle consists of a stance phase comprising 60% and a swing phase of 40%. Double support occurs for 20% of the total cycle duration. Symmetrical acute cerebellar ataxias can be caused by drugs such as phenytoin, lithium, or alcohol. Subacute causes include nutritional deficiencies in vitamin B1 or vitamin B12. Chronic symmetrical ataxia may indicate multiple system atrophy with cerebellar ataxia, or MSAC. Asymmetrical acute ataxia is often vascular, resulting from cerebellar infarction or hemorrhage. Rostral vermis syndrome, common in alcoholics, presents with a wide-based gait but proportionally less ataxia on the heel to shin test while supine. Arm coordination is typically normal or only slightly impaired. Caudal vermis syndrome, often seen with tumors like medulloblastomas, causes axial disequilibrium and a staggering gait. Spontaneous nystagmus and rotated head postures may also be observed. Hemispheric syndrome results in incoordination of the ipsilateral limbs, most noticeably in fine motor skills and speech. This is frequently associated with infarcts, neoplasms, or abscesses in the posterior lobe. Treatable causes of ataxia must be prioritized, including hypothyroidism, vitamin B12 deficiency, and Wilson's disease. Gluten-sensitive enteropathy with antigliadin antibodies is also a reversible cause of cerebellar dysfunction. Clinical takeaway: systematically localize the lesion based on gait, limb, and eye findings. Always rule out treatable nutritional and toxic metabolic etiologies before concluding a chronic degenerative process.